surgery changes the question fast. On Ozempic, semaglutide, or Mounjaro, tirzepatide, the issue is often not the drug in your blood. It is food that may still be sitting in your stomach when the team expects it to be empty. That is why some doctors tell patients to stop these drugs before surgery. The concern is aspiration risk, not drama. Standard fasting instructions assume your stomach empties in a fairly predictable way. These drugs can slow that timing, especially when treatment is new or the dose recently went up. A patient can follow the fasting rules and still arrive with more stomach contents than the team wants. That difference matters most when sedation or anesthesia lowers airway protection. If material comes back up, it can enter the lungs. That is called aspiration. It is uncommon, but it is serious enough that doctors would rather prevent the setup than gamble on it. I'm Dr. Kim, a licensed physician. This is not medical advice. Consult your doctor. That risk to the lungs is why fasting becomes a more careful question on these drugs. These drugs are usually not being held because of a direct toxic effect during surgery. They may be held because they can make the usual fasting clock less reliable. Stomach emptying means how fast food leaves the stomach and moves forward. Ozempic and Mounjaro slow that process. That helps many people feel full sooner and eat less. Near surgery, though, the same effect can become a problem. Fullness helps weight loss, but it does not help anesthesia safety. Patients often imagine one rule should fit everyone. Real practice is more individualized than that. A person on a stable dose may have no nausea, vomiting, or bloating. A person who just increased the dose may feel full after a few bites. That difference between stable patients and recently escalated patients explains why they may hear different instructions. The decision is often less about the drug name and more about the current situation around the drug. Symptoms matter. Recent dose changes matter. The kind of procedure matters too, often more than a simple internet rule. Procedure type is one of the bigger variables. Not every surgery creates the same risk that stomach contents could come back up and enter the lungs. A minor procedure without meaningful sedation is different from one that uses deeper anesthesia. Procedure length alone does not define the risk. Airway protection and sedation depth matter more. Procedure factors are only part of the story. Food timing matters too. A heavy meal with fat may stay around longer than a light meal. If that heavy meal is layered on top of slower stomach emptying, the stomach can remain less empty than the team expects. This does not mean one dinner causes the problem by itself. It means the risk can stack. Symptoms become useful clues here. Nausea, vomiting, early fullness, bloating, and repeated burping can suggest that food is not moving through normally. None of those symptoms proves the stomach is still full at surgery time. But they should make the team more cautious, not less. Feeling fine does not guarantee low risk, and skipping one dose does not guarantee a reset. Many patients want one simple sign that tells them they are safe. They want to say, "I held it, so I'm cleared." But real life is more annoying than that. The stomach does not always obey the calendar. That is why recent dose escalation can matter so much. When the dose has just gone up, stomach side effects may be stronger. The person may not look sick, but the stomach may still be behaving less predictably. Surgery teams care about that gap between how the patient appears and how the stomach may actually behave. Constipation can add another clue. It does not prove the stomach is full, because the stomach and colon are not the same place, but it can support the idea that the whole digestive system is moving more slowly than usual. That matters when the goal is confident preparation, not wishful preparation. That uncertainty about who actually has a fuller stomach is one reason the guidance changed over time. Early concern led to broad advice to hold these drugs before procedures. Later guidance became more selective in some settings. That does not mean the concern disappeared. It means doctors learned that the right answer depends on which patient is sitting in front of them. A patient on a stable dose for months, eating normally, and reporting no stomach symptoms may be managed one way. A patient in the first weeks after a dose increase may be managed another way. That difference can sound inconsistent from the outside. In practice, it usually means the team is separating lower-risk patients from higher-risk patients. Some teams ask for a liquid diet before surgery in selected cases. A liquid diet does not make risk vanish. It may reduce the chance that thick food remains in the stomach. That is a practical step, not a guarantee. It is one example of how teams adapt when the usual fasting plan feels less dependable. Some centers may also use an ultrasound scan to check the stomach. That is a bedside scan that helps estimate whether food or liquid is still sitting in the stomach. Not every center has it, and not every team uses it. The fact that some teams use it shows that this is a real anesthesia planning issue, not just an internet fear. The practical priority is not memorizing one simple rule from the internet. It is telling the surgical team the right details early. They need the drug name and the date of the last dose. They also need recent dose changes and symptoms like nausea, bloating, vomiting, or unusual fullness. Another practical issue is honesty. Some patients hide the drug because they fear a cancellation. That usually makes the situation worse. Late information forces the team to make faster decisions with more uncertainty. Sometimes the procedure is delayed anyway because the safest plan could not be built in time. This is also why surgeons, anesthesia teams, endoscopy teams, and dentists may not sound identical. They are not all solving the same problem in the same setting. One team may focus on keeping the patient much more deeply asleep during the procedure. Another may focus on a lighter procedure. Different contexts can lead to different instructions without anyone being irrational. Urgent surgery changes the picture again. If the procedure cannot wait, the team may proceed while treating the stomach as potentially full. That can change airway planning and other precautions. Elective surgery gives more room to pause, adjust diet instructions, hold the drug, or change the timing. Patients often ask whether the medication itself is dangerous under anesthesia. In most cases, that is not the core issue. The larger concern is that the fasting clock may say one thing while the stomach is doing something else. That is why the conversation is often about timing, symptoms, and preparation, rather than a direct drug interaction story. So the cleanest way to think about this is simple. Doctors may tell patients to stop Ozempic or Mounjaro before surgery for one main reason. These drugs can make the fasting clock look more reassuring than the stomach really is. The goal is not panic. Doctors are trying to reduce aspiration risk. They do that by planning for the stomach you may actually have, not just the clock on the wall. Medicine simplified. That's what this channel does. If you want more, hit subscribe. This is not medical advice. Consult your doctor.